This episode of The Dig is brought to you by our supporters at patreon.com and by Verso Books, which has loads of great left-wing titles, perfect for Dig listeners like you. One that you might like is The Authoritarian Personality by Theodore Adorno, Elsa Frankel Brunswick, Daniel J. Levinson, and R. Nevitt Sanford, with an introduction by Peter E. Gordon. What makes a fascist? Are there character traits that make someone more likely to vote for the far right? The Authoritarian Personality is not only one of the most significant works of social psychology ever written, it also marks a milestone in the development of Adorno's thought, showing him grappling with the problem of fascism and the reasons for Europe's turn to reaction. Over half a century later, and with the rise of right-wing populism and the reemergence of the far right in recent years, this hugely influential study remains as insightful and relevant as ever. This new edition includes an introduction by Frankfurt School scholar Peter E. Gordon and contains the first ever publication of Adorno's subsequent critical notes on the project. The Authoritarian Personality by Theodore Adorno, Elsa Frankel Brunswick, Daniel J. Levinson, and R. Nevitt Sanford. Out now from Verso Books. Welcome to The Dig, a podcast from Jacobin Magazine. My name is Daniel Denver, and I'm broadcasting from Providence, Rhode Island. There are weirdos out there walking around like vampires with $1 billion, and we've got entire communities where people grow up sick from toxic waste the state lets corporations dump in their backyards. The money to fund single payer and more is out there. We just need to take back the money that has been stolen from us instead of succumb to decades of brainwashing that teaches us that we need to cut taxes on the hyper-rich and their pervert corporations so they can keep more money they make by hurting us. That is Tim Faust from his book Health Justice Now, Single Payer and What Comes Next. What follows is my interview with him on that book, conducted last week in front of a live audience at Providence's Columbus Theater. One thing that we don't get into much detail on that is very important is that a radical Green New Deal would include Medicare for all, because we need to shift our economy toward good jobs in low and no carbon work that cares for people and nature, and away from the sorts of fossil fuel-intensive industries that are driving us toward climate catastrophe. And single-payer is a big part of that. Stay tuned for my forthcoming interview on the Green New Deal with Thea Riofrancos and Daniel Adana Cohen for more on just that. Before we get started, I'm getting ready to get out of town for the holidays, and I want to thank you all for listening. I am particularly thankful to those of you who support the podcast at patreon.com/thedig. I can only spend all of this time reading and preparing for each interview and paying for all the people and stuff that make the podcast run because of your support. That's what allows us to stick to our political mission and provide all of this great left-wing analysis to anyone who wants to listen for free, regardless of their ability to pay. The way that works is those of you who can support us do so at patreon.com/thedig. Plus, we have books to give you as a token of our gratitude, including my forthcoming book, All American Nativism: How the Bipartisan War on Immigrants Explains Politics as We Know It. That's patreon.com/thedig. Thank you. And one more thing before we get started. The gender balance of the question and answer session for this event was not good. In other words, mostly men asked questions. I'm pretty good at running a progressive stack, but found myself at a loss when it was mostly men who were coming up to ask questions. In the future, I'm going to more explicitly encourage people who aren't men to come forward. Okay, here's Tim Faust. He drives around the United States in his 2002 Honda CR-V, talking to people about health inequity in their neighborhoods, and is the author of Health Justice Now, Single Payer and What Comes Next. Tim Faust, welcome to The Dig.
Thank you. I'm happy to be here.
What motivated you to start driving around the country in your 2002 Honda CR-V, preaching the gospel of single payer to anyone who would listen everywhere, all over the place? In other words, before we get into a ton of detail about the policy and politics of healthcare, set out the big picture of how our current system of private health insurance works, how it injures, kills, bankrupts, and otherwise harms people by keeping them uninsured, underinsured, and on the brink of financial ruin. What's the scale of the damage being done and who's doing the damage?
Sure. So at its core, health policy is the determination of life and death. Who gets to live, who has to die, who gets to live freely in their own body, who is compelled to fear their own body, whose home is safe to live in, who are attacked and killed by unsafe housing, unsafe food, the police, the whole range of things that can hurt a person. That's all health policy. All things fall under health policy. And our model of health payment is privatized and fragmented. We've got public options for public payers like Medicare and Medicaid. We've got private insurance companies. We've got the VA all over the board. And nobody is accountable for the vast kinds of suffering which span America. We kind of push the suffering onto other actors, onto other payers. Once you suffer too much, you become too sick or too poor, you're put upon the public dole, but in a weird, fragmented way. Nobody is accountable for people's agony in the U.S. I got a chance to see this up close. How I got into this thing, how I got in my car and drove around, was I lived in California for a long time, which ruled. San Francisco was a nice place to be before Facebook IPO'd. And Wendy Davis gave her big filibuster. And I'm a Texan, and I watched Wendy give her filibuster and thought, well, shit, I should go do that. Not give a filibuster, but I should go get involved in politics and organizing. So I bought a 2002 Honda CR-V, which at the point in time had 184,000 miles, and now has 300,000 miles. So I've made pretty good mileage in the past 6 years, and drove around and got involved in campaigns. And I got a job working for Planned Parenthood in Florida, working on enrollment for the ACA, Florida, Georgia, Texas. The White House did not actually enroll folks in the ACA. It delegated the enrollment to third-party private companies, private organizations. Like Enroll America, if you've ever heard of them, is the biggest among them. They had
a microcosm of the whole program of this like tangled public-private mess.
Yep, pretty good. So far, great. Off to a great start. And Enroll America's model was horrible. And my job was to inherit this model, this data model, and put together maps of who should go canvass where. And our model was sending folks out to canvass folks, to enroll folks in the ACA. They're going to neighborhoods where there were boats in the driveway, which is a pretty bad sign if you're trying to enroll somebody in a public insurance option. I was like, oh, this sucks. This model's stupid. I'm going to build my own. I'm going to look at Zillow property values. I'm going to look at renter percentages. I'm going to look at poverty indexes and put together a map of where the poorest people in whatever city, Orlando, Atlanta, Houston, live. We're going to go there. We're going to canvass for the ACA. Except it turns out these are all Medicaid gap states. So we'd go and knock on the door and say, hey, we're here with the ACA. You want to sign up? Go through the form, check. Oh, I'm so sorry. You're too poor. You don't qualify for the ACA. Something had gone wrong. There was no Medicaid option available.
And that's because the Supreme Court said, actually, Medicaid expansion's optional.
Right, because the federal government would have been coercing the state into taking on a program it had not signed up for and making it pay more money, which is the argument. No one believed it. No one believed it would ever happen. But in retrospect, I kind of get it. But I'm also a deeply cynical person. Yeah, the states had the option to opt in or opt out of accepting Medicaid funds to expand Medicaid. In Florida, Georgia, and Texas, they're all opt-out states. So if you made less than, let's say, $14,000, you got no subsidy at all. You couldn't buy insurance whatsoever. If you made $14,001, or if you lied about making $14,001, which is always a pretty good choice, you could get ACA subsidies. So my bean was freaked. Why and how would somebody pass a piece of policy that actively hurt constituents? How this doesn't make sense. I'm going to get a job at an insurance company and see how the ACA can work. So I got a job at an insurance company, and I learned how the ACA could work. It works poorly, and it has worked poorly ever since I've been examining it. So my plan was to work for a Clinton administration, help HHS, kind of waited out and got on board single payer when Clinton got out of office. That didn't go great for a couple of reasons. So I said, okay, I'm going to go full bore and talk about single payer, do this thing I can do and talk about it where I can. So I went to go speak at the DSA conference in 2017, I think, and talked to a nice lady from Iowa City who says, oh, we don't get speakers about single payer in Iowa City. And I thought, well, that sucks. I've got a 2002 Honda CR-V. I live in New York. All it does is sit in the street all day long. Like a car that is not being driven is a useless car. Cars are only happy when they're being driven across the country. Why don't I drive around the country in a very ill-advised, spontaneous road trip and talk about single payer at various dive bars across the U.S.? And I did that. And it ended up being research for this book because it turns out the healthcare is local. The way that healthcare manifests is intensely personal, intensely local. Healthcare needs in Providence are different than healthcare needs in Boston, right? You talked about before, like a hospital financing. Hospital financing in Boston and hospital financing in Rhode Island are extremely different games. Healthcare needs in Roxbury, Boston, and Jamaica Plain, Boston, and I don't know, the North End are all very different. Healthcare needs in Boston and Brooklyn are very different. Healthcare needs in Brooklyn and Little Rock are very different. Little Rock and Fargo, like all these, like the things that happen to you that make you sick or make you die early or make you suffer, vary dramatically across the U.S. and across cities and across states. And the only way you learn that, in my experience, is by seeing it. So I got to see kind of the full weight. I'd go give a talk. Someone would talk to me, tell me the worst thing that's happened to them in their entire life. I would swallow solemnly and say, I'm so sorry. That would happen 20 more times that evening. I'd go and do the next day to kind of get an idea of how broad and how deep kind of like the daggers have been plunged into people across the U.S. And you asked who benefits from this. And the answer is the people that it's always that benefits. It's never a surprise who benefits from this, right? It's people that own private companies. It's insurance companies. Fundamental to the American healthcare puzzle are these two facts. One, it is not profitable to insure people who are sick.
That's a problem.
It's a big problem. Being sick is expensive. If we had no insurance whatsoever and you got sick, you get hit by a car, God forbid, you go to the hospital, you're looking at like $40,000 in bills. You can't afford that. So you got to buy insurance. All insurance is we pool together our collective risk. We're not all going to get hit by cars in the same day. So we all pitch in money when we have money. And when you get hit by a car or when you get cancer or whatever, you pull it out as you need. This kind of socialization of risk is called insurance. It's a great model that makes sense. But if you are an insurance company and you want to make money, if you are a private insurance company, if you have shareholders, for example, a really hard way to do that, if you insure people who are sick or expensive, it's very, very hard to make money by insuring them. So you want to find ways to avoid insuring sick people or expensive people or pass the buck or shovel costs off to other people. At the same time, if you're a provider like a hospital or a manufacturer, like an MRI or like an insulin manufacturer, equipment manufacturer, or whatever, it is super
or
profitable.
A pharmaceutical company.
Or a pharma company, yeah. It's if you're Martin Shkreli, it's super profitable to take a sick person who can't negotiate and charge them as much as you can as late as you can. Just, you've got kind of this Dr. Doolittle push me, pull you of contradictory forces, right? It's tough to insure folks who are sick, but it's very profitable to charge sick people a lot of money. And here's like why our insurance model is so totally hosed.
And then you don't even get things covered necessarily until you pay what can be incredibly high deductibles. I don't remember precisely what the bill I got once, but I had dislocated my shoulder, which was a recurrent problem I was having for a number of years. And my partner freaked out and called an ambulance, which if my shoulder hadn't been dislocated, I would have told her not to do because the bill was like $900 or something, and I'd had to pay out of pocket.
Right. I mean, ambulances are an entirely different ballgame as far as like what is and is not covered by insurance. That's pretty fucking wild, in my opinion. This whole thing is a series of boondoggles stacked upon each other. Yeah, I mean, like the American model of healthcare is you feel sick, you feel really sick, or your kid feels sick, so you gotta go to the ER, but you gotta know which ER you can or can't go to, because you go to the wrong ER, you get punished. So you play whack-a-mole.
Because you're out of network.
Out of network, exactly. The networks exist, so you gotta go to the right ER, but you can't take an ambulance, or you're gonna get charged for it. So you gotta like take a car or call a cab or drive. If you don't have a car, you gotta take the bus. If the bus is broken or you live in rural America, you gotta hitch a ride. You spend all day waiting for a ride to get to the hospital. You go to the hospital, you wait in line, you get your health care, and then you get a bill. And the bill is $2,000, $4,000, $13,000. Maybe your surgeon was in network, but your anesthesiologist wasn't, and you couldn't make a choice because you were knocked out at the time that you were getting an anesthesia, or shortly thereafter. You don't have any say in the matter. You can't do anything. And you're kind of cast away on the whims of this big machine, which does not care for you except to take money from your body.
It's really remarkable how quickly Medicare for All or single payer landed in the center of public debate. Bernie's 2016 campaign obviously had a lot to do with it, but Bernie was only successful in pushing this previously kind of exotic and marginal idea. And it was very marginal. I've been like, leftists have agreed on this forever, but until very recently, it was not anywhere to be heard of or taken seriously in the mainstream. And then suddenly in 2016 with Bernie's campaign, it explodes. But Bernie talking about it all the time, constantly, every time he opens his mouth, wouldn't have done anything wouldn't have had an impact if it didn't resonate so powerfully. Why was it that in 2015, 2016, because Bernie's been saying this forever, and Physicians for a National Health Program is saying this forever, why was it then that it suddenly had such an impact?
So there have been movements for single payer or universal health care that have kind of waxed and waned every 20-ish years since like 1940, right? And it keeps coming up and getting beaten or getting co-opted, sold out. Big union leaders, national union offices will sell it out or make a compromise. Senators will sell it out, make a compromise. This thing kind of waxes and wanes. The reason it's back up now is for three reasons. One is Bernie Sanders talking about it incessantly in the primaries, which was great. Two is the dissolution of the ACA. We're now one full cycle into the Affordable Care Act, and it sucks. If you guys know the Big Dog T-shirt company, Big Dog T-shirt company has a Big Dog T-shirt that says healthcare.goof, which I think is the most debilitating own of a...
Yeah, Big Dog's owning your program. That's ugly.
You're low-hanging fruit when Big Dog comes for you. I cannot find this shirt for sale, but I've been trying for 2 years. If you guys ever see it online, please email me because I need to buy this shirt. I don't care what size it is. I'll wear XXX. I don't give a fuck. So the ACA, we had 4 years of trying it. The big, like, I'll talk about this later, I believe. The big, like, shadow behind all these things, that medical costs skyrocket for a bunch of reasons. I talked about it a little bit earlier. If you can afford to charge more money, you do. So costs go up. So costs are going up. Insurance companies are passing the buck, passing the premiums back upon you, higher premiums, higher deductibles. You're getting worse and worse insurance. Subsidies aren't fantastic. You're still paying $400 a month for your insurance. You're paying more than that if you got a family. Everything's pretty rotten. This whole like shitty website is not solving your problem. It's just causing more problems. You got to push a button over and over and over again, and then it crashes and tells you you owe $20,000.
Did anyone else here try to use the Federal Exchange the first week that it was online? It was...
I had to because of my job. I made 20 different accounts on the healthcare.gov, which means I get 20 fucking emails a day now, reminding me to renew. But yeah, there's the whole backstory of why it was so bad is fascinating. It's the worst excesses of government contracting. It was a Canadian company who was known for making shitty software that broke, and they made shitty software that broke. They kind of got what they promised. But that if you are into software architecture, which I am a little bit, it is a horrible product. Like this thing was designed by people who had no business touching I don't know how they can go home and look their kids in their eyes. Horrible software architecture and back-end architecture. Anyway, the healthcare.gov ACA was not working. People weren't getting the care they needed. Some parts were working really well, though, like Medicaid expansion.
In the states that did it.
Medicaid expansion works great. What's the stat? In places where Medicaid was expanded, we saw a significant, I want to say 7-year reduction in mortality rates in places that had been expanded Medicaid. Massive, massive, massive difference. The difference between having no insurance and having insurance is literally life-changing. It saves your life, keeps you healthy for almost a full decade. Big, big, big deal. And then at the same time, this one good thing that had happened in the ACA was now being attacked by the GOP. The two folks who discussed the ACA the most discussed healthcare the most in the years 2012 to 2017 were Bernie Sanders and Paul Ryan. Obama did not make an appearance. Paul Ryan hammered the ACA as this big boogeyman that he wants to destroy, but in the process pointed out the few good things that did exist. That, you have Medicaid. Like it's good to have insurance. Not having insurance is much, much worse than having even shitty insurance.
People didn't appreciate the few important but good and important things about the ACA until the Republicans said we're going to repeal it.
Well, like a fundamental, like, as far as I'm aware, I wouldn't claim to be a political historian, but a thing that I've noticed in like history of American movements is that if you give somebody a material thing that they win, they fight very hard to keep it. People hate losing things, myself included. I don't like losing things at all. And so to even like this combination good and bad program, bad ACA, good Medicaid expansion,
good prohibiting the denial of insurance because of pre-existing conditions.
That was the big one, yeah. Like the ACA did two things extraordinarily well as outside of Medicaid expansion. It defined the idea of pre-existing conditions, and it defined a list of core benefits that insurance must offer. Insurance must offer, for example, contraception, preventive care, etc. Like if it does not contain these things, it is not insurance, which was a novel idea in the U.S. until the ACA came around. Essential benefits, and it defined pre-existing conditions, which we all call,
which is now kind of getting dismantled by the Trump administration.
Oh,
right?
yeah,
they're allowing all kinds of junk plans.
Junk plans are going to undermine that, but it's still like it gives us a standard to point to, which is good and useful.
Yeah, the whole politics of that. It's like the ACA heightened the contradictions around healthcare because it did some good things, but it also highlighted the absurdity of the current system by literally like allowing people to visualize the private insurance system and how dysfunctional it was. It was like, here are your choices. They're all bad.
Right.
And this is the best that the liberal establishment is going to do for you. So it both heightened the sense that healthcare is a right and demonstrated that the liberal establishment was not going to deliver on that right.
Right.
And then I think single payer is like naturally the next thing that comes from that, though I don't think any of us would have predicted that in advance.
I didn't. I really thought the ACA could work if it were treated fairly and like given the right chance. And then I learned how insurance works, and I learned, oh no, this thing is fundamentally incapable of doing the right thing. It requires massive subsidization from public money, from taxpayer money, et cetera, to do a shitty job. And this is a rotten way to determine who gets to live and who has to die.
I want to talk about Elizabeth Warren and Medicare for All and what her recent saga on this issue reveals about the state of healthcare politics. To recap, first, Warren, and I think what was kind of a politically canny move, stuck close to Bernie to try to disarm any critique from her left on the issue. When she was asked about single payer about Medicare for All, she said, I'm with Bernie on the issue. Then journalists tried to pin her down and ask whether taxes would go up on the middle class. And obviously this was a really rotten move on journalists' part because they were using this emphasis on raising taxes on the middle class to obscure the obvious reality that overall costs would go down. And one does not care like where the money's going out of, whether the money's going to taxes or to premiums. If your overall costs are going down, that's what matters. So that was rotten on journalists' part, but Warren played into their game on multiple levels. First, she refused to answer the question. Then she released a financing scheme that didn't make any sense just so she could say, no, taxes won't go up on the middle class. And then finally, she said, okay, here's how I'm going to get Medicare for All. I'm going to do this other plan that's not Medicare for All first. And then in like year 3, we'll get to that. And as a result, she's been clobbered from all directions. What do you make of that?
I think it's bad. I mean, it's like the political. Again, I'm no political historian, but the political capital of coming into office as a first-term president, you've got way more power to do things in those first 2 years than you do after you have the kickback and the midterm elections when you usually tend to lose seats. So why wait to do the hard things second? Secondly, you're kind of splitting up your energy, your momentum into 2 separate fights. both of which will be fought tooth and nail by the establishment, by the GOP. So why bother giving them 2 chances to beat you? I don't know. It doesn't make sense. There's this idea about Elizabeth Warren, but she always has a plan for everything, right? That's even her own meme, right? Which, cool, you got a brand, that's great. Her healthcare plans have been pretty actively bad, just bad health policy. Her first big healthcare policy plan was the maternal mortality plan. I don't know if any of y'all read it. Basically, she says some hospitals have very low rates. They're good hospitals, which is why they're on top, have very low rates of maternal mortality. And some hospitals have very high rates of maternal mortality. So we're going to take money from hospitals that do a bad job and give it to hospitals that do a good job. It's no child left behind, but for maternal mortality. But we understand why some hospitals have higher rates of maternal mortality, because they have poorer patients. They're in sicker neighborhoods. They have less resources. I mean, they're poorer hospitals to begin with, right? A hospital in a poor region with poorer patients is going to have worse outcomes than a hospital in a rich region with rich patients, because poor folks get sicker in more complicated and more severe ways. And so if this is your big brain genius plan to solve maternal mortality, you've got a shitty idea of how health policy works. And so I was pretty amped when Warren came out in favor of Bernie's M4A plan, but everything she's done since has sucked big time, and I don't care for it.
And the punditocracy's assessment of why her ascent in the polls has come to a sudden halt as a result of all this is totally backwards and perverse. They say, look, she suffered because she supported M4A. Whereas Bernie Sanders was asked in these same debates, will taxes go up on the middle class? And he just answered, yes, but overall costs would go down. Next question, and wasn't damaged.
It's easy. It's very simple. As Zaza Gabor says, it's simple, darling.
Let's get into some more depth on healthcare costs and how that plays into the politics of all this. Yeah, you emphasize that hospitals, pharmaceutical companies, device manufacturers, that they're like the villains behind the villain of insurance companies in terms of what drives up costs so high. Insurance companies don't have the power to bargain for lower prices. And so there's this twisted dynamic that you mentioned earlier where insurance companies are incentivized to cover the fewest possible sick people and to deny payments to as many people as possible when they do get sick. And then on the other hand, providers, when they get their hands on a sick person, hospitals, device manufacturers, pharmaceutical companies charge as much as humanly possible. Explain this dynamic between providers and insurance companies and how that drives costs and how that impacts people.
Sure.
i.e. patients.
You've got a new order, bizarre love triangle kind of scenario going on. So we'll start with costs. Costs come from, as you said, providers, hospitals, specialists, doctors, equipment manufacturers, Martin Shkreli, and some manufacturers, the whole wide world, right? And they can control costs in various different ways. A good example is MRI machines. Y'all know what MRI machines are. They're just big fancy computers that print money. In the US, the average MRI scan costs 5 times more than the same MRI scan performed with the same machine when scanned in Australia. Now, keep in mind, this is the same computer doing this. You push button, you get scanned. It's the same computer doing the same thing, but the cost is 5 times, just because the costs are high because the prices are high. It's the prices, stupid. In even the same MRI machine, in the same hospital, in the same room, there's a survey done by Sarah Cliff, then of the Washington Post, of MRIs in DC. And she found that the literal same MRI tube in the same room, in the same hospital, would have a 7-fold cost variance based upon things like what doctors are nearby, what the insurance company is, what time of day it is, what part is being scanned, even though it's the same button that you push. These prices are totally fake. This is a totally fake calculus. It's alchemical. You can never determine what the price is going to be until it happens. You've got some of the best and brightest out there trying to guess what prices could be, and no one can answer the question. Prices are totally fake. And they've been increasing since we first began recording healthcare costs back in the 1870s. Costs have always been going up. They go up everywhere in the world, but they go up especially fast in the US. Part of that is for normal reasons, good reasons. Folks live longer. Folks can get more healthcare. More kinds of healthcare exist, so they're going to live longer and spend more healthcare. That's cool. That makes sense. But a lot of it's for these shitty artificial reasons. Prices just go up because they can go up. Martin Shkreli, 17 upples the cost of a drug overnight, and all of a sudden those costs skyrocket. Insulin triples in the past decade for no apparent reason. There's no new costs in making insulin, and so therefore diabetes care skyrockets. So
and insurance companies are evil, but they happen to not like this, just like we don't like this. But why can't they do anything about it?
Because they got no negotiating power. So insurance companies are just incompetent, right? They get settled these costs and they go, well, shucks. So, sorry, your insulin's so expensive. We can't do anything about it. Hope you better have to pay $900 now. Insurance companies are totally incompetent to bring down healthcare costs because insurance companies need hospitals and insurance companies need insulin manufacturers way, way more than hospitals need insurance companies or insulin manufacturers need insurance companies. If you are in a city with one really big hospital and 3 small insurance companies, that hospital can go ahead and pick it. It doesn't need, if you're this one small insurance company has no leverage over that hospital's pricing. They can't do anything about it. All they can do is roll over and take the costs and pass them back upon the person. So we saw this problem happening in the 60s and 70s, and we came up together, everybody in America, with a brilliant solution to stop this problem. It's called consumer-driven healthcare, in which you take the consumer, which is the libertarian way of saying the word people, and make them bear. That's fun. Make them bear more of the costs on their own. Right? That's why your premiums go up, or your deductibles go up, or your copays exist.
People have to have some skin in the game.
Which is a perverse thing to say because your skin is literally the game. The game is in your skin. You can't have more skin in the game. It's very stupid, but it's a great way to keep costs, to try to tamp costs down by deflating them and pushing them onto people. Because it turns out if people can't afford healthcare, they just don't get healthcare, and therefore costs go down because no healthcare is used, but people die.
And it's premised on the idea that costs are going up because people use too much healthcare.
Utilization.
Where does that even come from?
There's this idea. So you've got 2 things there. I'll get pedantic for a second. Sometimes healthcare utilization is inefficient. Folks go to the ER for things they could go to primary care for.
But that's because they don't have access to primary care.
Exactly. Yeah. And sometimes hospitals do things that aren't. Sometimes hospitals will give you 2 drugs when you only need 1. Hospitals will do things to jack up costs. That's a real thing that exists. But it's not like people are utilizing poorly.
So people are really going to be like, I'd like another MRI, please.
Right. No one's.
And they're like, no. And you're like, yes.
No one is getting recreational healthcare. There are some folks out there, obviously, who are made into the examples of folks who are drug seekers or attention seeking or whatever, and they do need healthcare. It's just social work and mental health work, and not like ER work, and that's doable. And an emergency department knows who these folks are and could route them if I wanted to. It just chooses not to. But yeah, there's this myth that the American consumer is this loathsome and selfish little goblin who uses healthcare in all the wrong ways and must be gently corrected through severe fiscal discipline.
For what motive? It's unfathomable. What would be the motive of someone just maxing out on unneeded MRIs? I just don't know.
They just don't know. The big one is they just don't know when to not go to the ER, right? They just need to go to see primary care before. But you can't fucking afford to go to that either. People wait. Yeah. And we understand why people wait to go to the ER. This is a thing that we all probably have done or will do in the next 5 years because I've done it before and I'm sure it'll happen to some of you. You just don't go to the doctor because you can't afford to pay the doctor. So you wait until things get real bad. Then you go to the ER. That's how it happens. Duh. It's simple. Sounds like a bore. The insurer isn't capable of seeing this because they can't do anything about that, right? So they push costs onto you. This thing keeps building up. People suffer and die.
Putting healthcare spending into one big democratically controlled collective pot will not only bring down healthcare costs, it'll also allow us to spend healthcare dollars differently to more beneficial and just purposes. What should society's healthcare spending be redirected from and toward? And how can single payer make that happen?
Hell yeah, buckle up. So there's a couple of there's an easy, like, basic answer that we hear in a lot of single payer work, and then I think there's the more satisfying, deeper, more aggressive answer. The easy one is, right now we spend a lot of our time on urgent care, on crisis care, on specialty care. We can shift that money over and put it in primary care, preventive care, the gentler kind of GP work, family doctor work that we see and we need. That's true. That makes sense. But there's no guarantee that that money won't decrease. We might spend more money on primary preventive care under a single payer model, which isn't necessarily bad. Healthcare spending is good in general. Healthcare spending has a 6.1 multiplier effect. It's a generative spender, but, like, that's not where the spending benefit of, or the spending impetus of single payer ends up. Here's my thesis, the thesis of the book. Once you force the federal universal single payer to bear all the costs of providing care, it also bears all the costs of what happens when care is not provided. If your people who you're treating or who you pay for don't have a place to live, so they go to the ER whenever it's hot outside or it's too cold outside, or where they live is flammable, ghost ship in Oakland, full of water, full of mold, full of poison, and so they grow up sick and die young and are expensive, then housing is healthcare. If you want to bring down housing costs, healthcare costs, you got to invest in safe social housing to bring those long-term costs down. If people are dying because they don't have access to healthy food to eat, it's not profitable to sell a poor person vegetables, so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you got to provide people with affordable or free food options and the time, space, and materials to provide them to bring those long-term healthcare costs.
Confronting climate changes healthcare.
Yes.
Extreme weather is obviously dangerous in terms of what extreme heat does to people, in terms of activating allergies, in terms of extreme weather that knocks out power and thus people's access to ventilators, which killed people in Puerto Rico.
It makes somebody accountable for all this suffering. Right now, there is nobody who's accountable for the suffering. Nobody really bears the cost. The families bear the cost. The communities bear the cost. But no, like, payer entity bears the costs of these massive acts of tragedy or trauma. A single payer finally is forced to confront these things, and therefore, because it is democratically controlled, can be used to, like, invest in the things which protect us long term. That is the idea of health justice, that healthcare stretches far beyond what happens in the hospital, right? And environmental justice, therefore, is health justice. Economic justice is health justice. Justice for Black lives, and brown lives, and trans lives, immigrant lives, that's health justice. Reproductive justice is health justice. All these things belong together in the same pot, and the way that they manifest have consequences in our bodies, and therefore consequences that we can see in our healthcare spending, and therefore we should use our healthcare spending to take care of these things long term and invest in them before the problems arise.
And in terms of immigrant justice, very notably, at least in Bernie's policy, and I assume in Jay Paul's policy, but I'm not sure, people are included regardless of immigration status, which is really great and really quite radical when you think about it, that for decades, anti-immigrant politics in this country have been organized in large part around the idea that undocumented immigrants and immigrants in general are mooching off of taxpayer-funded welfare programs. And so to have them be truly universal is just a great thing.
Yeah, it's good.
Yeah. All right. But okay, so that's like the big picture of what we should be doing with those dollars. But to talk about something like a little more concrete, primary care physicians right now under the current system, they're the bedrock of the healthcare system, but we don't have enough of them, but in part because they're paid, you write, almost 3 times less than specialists. The result of this is that people don't get the preventative care that they need, which is, of course, first and foremost, horrible for their health, but it's also really expensive because they end up showing up at the ER. How has the current system managed to systematically shortchange these doctors that we know the best and rely on the most, our general practitioners, while making many specialists really spectacularly rich? How could single payer change that? And do we need to knock specialist incomes down a bit and pay primary care docs more?
Yes, to many of those questions. So there's a couple of bad guys, a couple of factors that take us into this. One, baseline physician income is set by is based upon often Medicare scheduling. And Medicare prices are set by a committee that is advised by the AMA's Senate, you could say. The Rules Update Committee, Relative Value Committee, RVC, under Medicare, determines what different things cost that Medicare pays for, and that becomes the bedrock of how costs are set across the U.S.
But the AMA's Senate is about as democratic as the U.S. Senate,
right?
In terms of its representation,
right? They have two people representing all primary care things, and 5 representatives for the 5 fingers of the hand for hand surgeons. For example, that's an exaggeration, but it's not too far off. You've got way more hand surgeons, brain surgeons, heart surgeons, eye surgeons, other kinds of surgeons. Specialists.
Picture a body part and whoever does that one.
And a couple of primary care docs, and they all have equal voting power. So therefore, all these prices, they have to present a sheet that is zero sum, so it backs be the same. Here's a real example. This happened a couple of years ago. I'm going to really simplify it because that's the only way that I understand it. This committee, this AMA committee, put together the idea that there were now 2 kinds of knee surgery. Before there was only one kind of knee replacement, let's say. And they said, oh no, now there was 2 kinds of knee surgeries. There's an easy one, happens half the time, go ahead and charge half the going price. There's a hard one, happens half the time, charge twice the going price. On paper, this adds up to being the exact same cost before as you would afterwards. But this meant that every knee surgeon going forward only billed at the higher priced one, and costs went up a lot. And knee surgeons brought home a lot more money. And that's money that came out of the hands of primary care providers. So you've got that happening. Specialists keep finding ways to give themselves more money using the Medicaid rule structure. That's a thing you got to get rid of. You can't give the AMA privileged treatment over price setting. That's a bad relic of a very antiquated model of how government and third parties work together. Stupid. But also you've got something more, I think, basic to this, which is if you're a med student, which is how you become a doctor, you go into med school and you see 2 charts, right? One is a number of your projected income per specialty, right? Down here, you've got primary care. Over here, you've got Ben Carson brain surgery. And the graph goes like this. You get paid way more to be a brain surgeon than you get to be a primary care provider. The second graph is your student loans. You're looking at 2, 3, 4 hundo thundo of student debt to pay off. So if you, here's an example. I met a doctor in rural Kentucky. I would say Lexington. She was a nice old lady. Well, I don't want to say old lady. She was a nice lady. 67 years old, primary care provider. And she couldn't retire, she thought, because if she were to retire, nobody could afford to move to where she lived and be a primary care provider. It doesn't pay much money to be a primary care provider in rural Kentucky. And if you've got 3 hundo thundo in student loans, you can't even pay off your own interest on a PCP salary in a rural area. So I think if we want to really, so that's why we have not enough primary care providers and too many specialists, you could say. This is a totally invented problem. In the early 90s, we thought we'd have too many primary care providers. There's a New Yorker cartoon of doctors in the breadline because we have too many of them. And so Clinton-era austerity programs began putting really hard caps on residency programs. There's a lot of efforts to shift folks away from being primary care providers, reducing med school applications and residency programs. These are all things that we did. Therefore, the things that we can solve. I think
other cool things from the Clinton administration.
Yeah, they're like a little.
So many cool things from the 90s that happened thanks to Bill Clinton. It's just good stuff.
The only good thing from '92 is Alice in Chains. And sorry, of course, Kurt Cobain. But so the answer to this thing is pretty obvious, right? Make medical training free. Not just med school, but nurse training, home health training. This is a civil service. Make the training to be a civil servant free or subsidize it, right? Therefore, you can afford to come from Fargo, go to med school, go back to Fargo, be a doctor that you want to be. Therefore, you need not go into hand surgery to pay off your student loans. Therefore, another problem on top of this is that right now, what is it? 70% of people in med school come from the top 2 income quintiles. Only the children of doctors can afford to become doctors in the first place. So you have a body that is increasingly unrepresentative and disproportionately wealthy. That's how you get a lot of problems. When doctors don't look like or come from the same place as their patients, they give those patients worse care. There's a lot of implicit or cognitive biases that go into medical care. And so we're building this army of mostly wealthy, mostly white hand surgeons, and they're fucking up. at taking care of primary care, like in like the rural South, for obvious reasons. So I think the answers are single payer doesn't solve this overnight, but I think only single payer could be used to solve these problems. I think single payer bears the cost of these problems and is a tool that can be used to realize, oh shit, we should make medical training free. I think Bernie's student debt jubilee program, I'm not sure if it applies to med school, but it should. I don't know if I'm happy or determined at this point. But I think making medical training free, making medical training subsidized is like a fundamental component of building the workforce we need to take care of people.
One of the core things about Medicare that single payer would expand on is obviously the power of a big insurer to dictate prices to providers. But you make the important point that Medicare as it currently exists isn't what we want to just straight up expand into Medicare for all, because Medicare as it exists is far from ideal. It's a cluster of different programs that have a lot of limitations on coverage, that charge for a bunch of different things, and also have a component that's like privatizing the whole system from the inside. To start off, briefly explain Medicare Parts A, B, and D, just so people know what they are, because I didn't really understand them until I read your book. After that, we'll get to the truly nefarious privatizing Part C.
Fun alphabet soup. Medicare, traditional Medicare has three components, A, B, and D. A is hospital care, emergency care. You get that for free if you've been like a traditional salaried employee for, I think, 25 years, which means if you're a stay-at-home parent or a homemaker or you're like a non-traditional employee, your host, you got to pay $450 a month to get a Medicare Part A, and that covers emergency care to up to a point. You get hit by a car, you get cancer, you get leukemia, you get the Black Plague, you can go to the hospital and get taken care of. It has a copay and it has deductibles, and it's not perfect. Part B is primary care, or like non-urgent, non-critical hospital care. That's like you get a knee replacement and you have physical therapy. You get a knee replacement in general. Got a bad lung, you got to go to the doctor pretty regularly. Part B has a premium. You got to pay to get it on a monthly basis. That can come out of your Social Security payments. So it can be, in theory, an invisible premium.
Except then you're not getting Social Security money.
Not great.
Yeah.
No one's happy with this arrangement. It also has a copay. I believe it has an 80%. It covers 80% of costs. You got to pay 20%. Also has a $2,000 deductible. I could be wrong on that one, but it has a deductible as copays. The copay is the much bigger deal, and it has no out-of-pocket limit. So you can, in theory, spend 20% of your medical costs indefinitely. And then Part D is drug coverage. You spend money and you get some drug. You get some Medicare drug coverage programs. The question right now, if you want contemporary stuff, is whether or not Medicare is going to be allowed to negotiate its own drug prices. Right now, it can't. Right now, it has a rules-based process for determining what it pays for drugs based upon what the cheapest or third cheapest private insurance drug cost is, which is horseshit because private insurance company. It's in the book. It's a long story, but that's Part D is drug coverage. So it's pretty piecemeal. And if you want all three of these things, you got to pay for all three of them together. And you have this big monthly thing you got to pay for. And this is not the Medicare we want to have for all.
It's not like we have single payer for old people right now.
No, not at all. Medicare for all is used because Medicare for all polls well. People like the idea of Medicare is the concept, not the technical expression thereof, but the concept is gettable. It's a federal program that you have access to, but the actual implementation is not the thing we literally want for all people. Some folks use the term expanded and improved Medicare for all. I use single payer. My preferred terminology: federal comprehensive universal single payer, anagrams to FUXP, which no one has adopted yet.
What a shame.
But I think
you're onto something.
I think that's the movement we need. But yeah, Medicare, the thing we will run into at some point, and the thing that I run into is a person who's on Medicare saying, "I don't like Medicare. It's really screwing me over. Why would we want to have this for all people?" To which the answer is, "Oh, not actually Medicare. It's better Medicare," which is kind of hard to have the conversation. But there's a trade-off there. How do you do this thing?
It's not an ideal term, but it might be the best we have. And either way, it's too late. It is it is the term.
Right. I think in the West Coast, the Medicare for All buttons say, improve it, expand it, Medicare for All, which is a nice way to dodge that problem.
Okay, so Part C, aka Medicare Advantage, allows private companies to offer Medicare coverage that provides a bunch of benefits that normal Medicare doesn't, all while being subsidized by the government. You write, quote, does it seem like maybe the standard Medicare plans have been hollowed out or made weak so that Part C seems like the most appealing option? Part C has represented an increasing share of American medical costs over the past few years, even though it's a woefully inefficient use of government money. You might even suspect that the relative weakness of Parts A and B is intentionally designed to drive people into the privatized Part C option. I do. Explain how Part C came about, how it works, and how it's functioning to privatize Medicare.
Cool. So Medicare, everything in the U.S. medical history, medical policy right now has been built incidentally or accidentally over the past 100 years. It's a big Frankenstein monster. It's like how if you're building a monastery and you build it 1,000 years ago, and then you add on some new rooms and bulldoze a wall, and then you add some new rooms later and build another wall, and you kind of get this big weird building with rooms that don't match each other kind of thing. That's Medicare. That's how Medicare is apportioned. That's how insurance works. And so parts A and B are clearly inadequate for a lot of the things that people need, especially the out-of-pocket limits. As you live longer, have more chronic diseases, people are living past 67, which was not the case 70 years ago. Thank God, because my dad is 69 and I want him to live a lot longer. These long-term costs really begin to stack up. And so to handle this, instead of making Medicare Parts A and B better, we decided to let the free market handle this by letting private insurance companies get in the mix. This really began jumping up in the 80s and 90s and provide their own kinds of insurance programs to Medicare.
To let the free market handle it with government money.
Right. We'll pay them to handle it. That's the free market. That's how the free market works. You pay the free market to take care of problems, and then you pay them more later when those problems get worse. That's the market. That's the free market. It's free money for the market. It's free real estate. So Medicare Advantage, you've probably seen these things. You've probably seen these, they'll bring trailers out to community centers. They'll talk to folks. They'll offer people little gizmos and gadgets, Fitbits, Silver Sneakers programs, cookbooks, little exercise classes. That's pretty cool. But really what Medicare Advantage programs do is they tend to cream skim. They take the healthiest Medicare recipients because, again, if they were to take people who were sick, it would be expensive to insure them. They don't want to do that. Every year, the private insurance company and Medicare kind of come to an agreement of this. We think this person is going to cost $10,000. If they cost more, the private insurer pays the bill. If they cost less, the private insurer gets that delta as pocket money for themselves. That's the way the structure works, which has two consequences. One, Medicare Advantage wants people who are probably going to be healthy, so they don't have to pay anything out, and then they want to over exaggerate how sick they think this person is. So they get a reimbursement at the end of the day. So Medicare Advantage tends to take on people who are not very sick. We know that because when people get sick, they churn out of Medicare Advantage really, really, really quickly. Medicare Advantage has private insurance networks, hospitals you can go to, hospitals you can't. But it also doesn't have out-of-pocket. It also doesn't have out-of-pocket spending all the time, or it has a cap. It might have a lower deductible. It can do things like offer Lyft rides to the hospital. Lyft and Uber have massive Medicare Advantage programs and integrations. And it can offer little gizmos and gadgets and little charms and gewgaws and stuff.
So if you're not too sick, it can seem a lot better.
And it is. Yeah. It is. It's a better program if you're not very sick. And it's because you no longer are paying that 20% of out-of-pocket costs every time you go to the doctor, because this private insurance company has negotiated down because they can. Because they're given permission to do these things that traditional Medicare can't do. If we let Medicare restructure itself and do these things, it would overnight, and it would save money and be a better program. But it's not in anyone's interest for that to happen. So that's one thing Medicare Advantage does. It skims the cream and then makes it difficult to get care when you actually need it, when you actually are sick. People churn out and go back into traditional Medicare and buy secondary programs called Medigap to cover their out-of-pocket costs. And then it does a second thing called risk adjustment or upcharting. Because at the beginning of the year, Medicare and the private insurer come to an agreement of, we think this person will cost $8,000 this year. So that's the bar we'll set at. The insurer wants to both spend less than that, but say the person is sicker. So they'll do a thing like this. A person has a chart saying they have kind of low potassium levels. Insurer sees this and has a doctor call them and say, hey, we noticed you've got low potassium levels. Do you think you have hypoglycemia?
Glycemia? Do we have some doctors over there?
What's it? Thank you. I can't say that word. It's called hypo-K. We saw that you have low potassium levels. Do you think you might have hypo-K? Can we get in there for a screening? They'll send a doctor over who'll poke and prod. And often, like, the line between what is and is not hypo-K is art, not science, right? Like, what is low potassium? Who fucking knows? So, in January, this person went to a doctor and they had low potassium, but it wasn't that low. The patient seemed fine. They weren't like going to the doctor because of this. It was just like a side symptom, whatever. Okay, fine. They went on with it. In December, the insurance company says, oh, we want to get that money. We're going to send a doctor to your house or to your hospital bed. And we're going to get you a diagnosis of hypo-K. And we're going to get that sick money at the end of the year from Medicare. We're going to find ways to get you upchart you, give you more diagnoses, and then reap that money for ourselves. That's called upcharting. It happens a lot to the tune of like $7 or $8 billion a year. There was a big whistleblower case in Minnesota where I think United said that the former United CFO said they were doing $30 million a year in fraudulent upcharting. It's a big business. Medicare Advantage is the public subsidization of private industry for no good reason whatsoever.
It's a microcosm of Obamacare.
Yeah. It's a similar structure, right? Because you have similar programs in ACA insurers as well. They also have a version of risk adjustment, although it's not being funded because the House hasn't funded it for a long time. But pretty similar model.
I'm Naomi Klein. You're listening to The Dig, as well you should be, and you can support them on patreon.com.
This episode of The Dig is brought to you by our listeners who support us at patreon.com. And by Verso Books, which has loads of great left-wing titles, perfect for Dig listeners like you. One that you might like is Capital is Dead. Is This Something Worse? By Mackenzie Wark. In this radical and visionary new book, Mackenzie Wark argues that information has empowered a new kind of ruling class. Through the ownership and control of information, this emergent class dominates not only labor, but capital as traditionally understood as well. And it's not just tech companies like Amazon and Google. Even Walmart and Nike can now dominate the entire production chain through the ownership of not much more than brands, patents, copyrights, and logistical systems. While techno-utopian apologists still celebrate these innovations as an improvement on capitalism, for workers and the planet, it's worse. The new ruling class uses the powers of information to route around any obstacle that labor and social movements put up. So, how do we find a way out? Capital is Dead offers not only the theoretical tools to analyze this new world, but ways to change it. Drawing on the writings of a surprising range of classic and contemporary theorists, Wark offers an illuminating overview of the contemporary condition and the emerging class forces that control and contest it. Capital is Dead. Is This Something Worse? By Mackenzie Wark, out now from Verso Books. As with many things in life, I think we can learn a lot about healthcare by how it treats poor people. And so I want to talk about Medicaid a little, which is obviously a lifeline for a lot of people, and its expansion in those states where it's happened has been hugely important and life-changing, as you said earlier. But it's far from an ideal program. Many fewer doctors accept it than Medicare because the reimbursements are lower. States have a lot of power to decide who's eligible and who's not. And tons of people who are unquestionably too poor to buy insurance in the private market don't qualify. And now under Trump, his administration's allowing states to impose work requirements for Medicaid, which operates under the presumption similar to like with food stamp requirements that people are poor because they're lazy rather than that we live on a like ruthless neoliberal hellscape. So explain how Medicaid works and has worked, and more generally what that reveals about how our system treats poor people.
Sure. So Medicaid is a program that is funded in a combination of state and federal financing. In wealthier states, the federal government pays more of the money. In Mississippi, 75% of Medicaid funds come from the federal government. In California, only half. And as a result, the state has to put some of its own money into the program, right? And states have limited budgets in ways that the federal government does not. States can't print money is the big component of it. So states have kind of an austerity approach to their own Medicaid programs a lot of the time. And so Medicaid is used as this like cudgel to beat back poor people and harm them and other them and find ways to means test them so that they can, under the guise of saving money and keeping the state fiscally solvent, right? Work requirements are a great example of really, really horrendous forms of means testing because nobody, like most people on Medicaid, are working. They're just not working jobs that give them insurance or not working jobs that pay them enough to buy their own insurance, right? But now they've got to go to an office and wait in line for 3 hours. In Tennessee, the office doesn't even have a single database of all the Medicaid recipients. And wait in line. That's time they can't spend going to work. That leads to further and further problems. Work requirements are a form of means testing, which is a process of determining who is the deserving versus the undeserving poor. That's a theory that dates back all the way to eugenics, modern eugenics. It's a horribly like racist and sexist and ableist program. And Medicaid is, on one hand, it's a fantastic program that's been used to do a lot of really extraordinary work for a lot of people. Medicaid is the laboratory of American healthcare. A lot of great programs come through that. Housing programs in New York are extraordinarily, and they're Medicaid funded. California has some great ones. The Strong Start program, which handles prenatal birth weight, is a fantastic program funded through Medicaid, but it's also being used to punish people who are undeserving. And so you kind of see this like rallying cry that you've seen kind of across the US, and that Medicaid is used to say, oh, these people are getting away with free welfare while you poor person who is not on Medicaid, are suffering otherwise. It's this form of like identifying an other and castigating them to build a
so it's not just to punish the poor person, it's to spectacularly punish them in a performance for the broader political effect.
Right. And I mean and it's in some states you got to make less than it's gotten so austere that in some states you got to make less than $7,000 a year to qualify for Medicaid. In Texas, you have to make less than $7,000 and be either a single mother, blind, or physically disabled. You can't be just poor. You got to be poor and another category. We've really found ways to really put the thumb screws on people who need benefits through Medicaid.
At present, there's a whole lot of healthcare that's excluded from the category of normal healthcare for reasons that are hard to understand when you need to use these sorts of health services: mental health care, dental, vision, reproductive care, including notably abortion. In the case of abortion, the politics are more obvious and unfortunate, but how did dental and vision and mental health care get deemed like not actually core healthcare, as though there's some sort of like bonus healthcare?
These are just accidents of history. No one designed the American healthcare model. This is a bunch of accidents of things that got stapled together, like a big pile of paper that got put together over 70 years. And so back when like healthcare benefits began, like insurance came about when a hospital in Waco, Texas, put together an arrangement with some teachers unions at Baylor and built a insurance model off of that, and things grew from there. Dental and vision and mental health care weren't considered at the time. So like right now, like nobody prognosticated how healthcare would evolve 70 years ago to today. So these things don't exist because no one thought to put them there in the first place. This is not like an intentionally designed program. What single payer can do is kind of correct course correct and say, oh no, we understand what healthcare looks like now. Things have changed a lot. Here is the full swath of what healthcare canons. Like there's no reason to have vision insurance be separate. That's stupid. Very profitable, but very, very stupid. Single payer can kind of like write the chorus, retcon the past, and say, nope, these things are healthcare. These things belong together.
Yeah, because I like can't work or go about my daily life without glasses, just like I can't if I have some other medical issue. It's like it's medical. It's bizarre that
it's your body. This is all body health. These things all belong together.
Another form of care that our current system systematically shortchanges that you write about a bunch is home care. People who need assistance getting cared for in their homes. And it's incredibly hard for people without enough money to receive sufficient care at home. And so they often get pushed into nursing homes against their wishes. How does that system operate? And what does that mean for these people who are forced out of their homes? And how would single payer fix that?
Okay. Nursing homes are a place where you go to die. That's the long and short of it. It's they're usually private. They're usually horribly run. In Arkansas, a state rep was found to be on the payroll of a nursing home, and that state rep is one of the guys that wrote a bill making it harder to sue for malpractice. Like rotten to the core, toe to tip. I got a buddy with cerebral palsy. His name's Steve. He can live at home through Medicaid. Medicaid will pay for his mom or his friend to take care of him with like getting around the house, going to the bathroom, getting dressed or whatever. But because of that, he has to make less than $2,000 a year to qualify for it. It's a year. And he makes more than that. He loses funding and would need to go into a nursing home. And in a nursing home, he would probably die. Nursing home, you don't get to pick where you go. You're at all the staff is undertrained. The care is leveless.
And underpaid.
Deeply underpaid. The goal is to get number of bodies and beds and minimize care provided to them. It's home to some of the worst stories in American healthcare. And of course, this especially in nursing homes that serve poor people. And so home health movement, which emerged really aggressively, especially in the past 20 years, and home and community-based services is like a really emancipatory healthcare movement. The idea that we can spend this money we would spend in nursing homes to pay my friend or my parent or my loved one or whatever to take care of me at home so I can live life with the dignity that I deserve, doing the things that I can do in a place that I feel comfortable and safe and familiar and loved. And this is a thing that actually wasn't in Sanders' healthcare bill until this year. Jayapal put it in her bill when it came out. And then there was a big outcry, there was a big push rather, from disability rights communities, disability activists, to get Sanders to include it in his bill. And he did. There's a bunch of talks in February. He added it to his bill for the first time this year. And now it's a great single payer bill. But long-term care is the largest growing sector in American health. I think there's 1.2 million home health aides in America right now. There'll be 3 million in the next decade. Because long-term care is also for people who are elderly, right? You get Alzheimer's or you get sick. You don't want to go to a nursing home or a senior home. You can stay at home, have someone take care of you. But these people are paid, I think, a nationwide average like $10 an hour, $11 an hour. So they can't afford to take care of themselves. Like my buddy Kyle's a home health aide. He can't afford to pay his own insurance premiums on his home health aide salary. So we're building this massive workforce of compassionate laborers. And compassionate labor is really the thing that makes a difference in healthcare. All the advances in healthcare don't come from hospitals or drugs or gizmos or specialists. They come from nurses and social workers and home health aides. The people that actually make a material difference in health outcomes. And they're systematically devalued and underpaid and cast away and kind of stomped underfoot. And you kind of see these things coalesce in the fight for long-term care and home health.
The last question before we go to open it up for questions from people who aren't me is how do we actually do single payer? Do we have to nationalize the health insurance companies, or do we just outlaw them? And how does it work? How do we deal with the 2.6 million odd people who work for the health insurance industry? Because you write, quote, single payer doesn't erase jobs or make them redundant. If it wants to get its work done, a single payer has to create jobs, a lot of jobs, meaningful jobs.
Hell yeah. So there's a couple of things there. One, first off, what do? We got a couple of options. You can either let insurance companies starve and make them not able to compete and let them close down, or you can buy them out and nationalize them. I think the latter option is probably easier to do for a lot of reasons, and we can afford to do it. It would cost, I think the estimate was I think I saw this in Jacobin in 2010. So I guess right after the recession, the cost to nationalize the insurance industry would be something like $800 billion, but we spend $3 trillion a year in healthcare. So that's a long-term, that's a thing we could afford very easily with the savings we get under single payer. But the more important question, the more interesting question is, what about insurance worker employees? And so here's my answer to that. Most people that work in insurance companies work in either a call center or work as nurses. Call center people receive calls, and a person says, "I need to go. I can't understand my bill. I need to go to the doctor, et cetera, et cetera, et cetera." A nurse calls a hospital and fights with them on the bill, or calls a patient and tries to get them to go to the right doctor at the right hospital. These are roles that ultimately have one purpose, which is to take a person who needs care and limit or corral the kind of care they can receive. But this skill set is really important and really valuable. And so let me take a second and give you another anecdote of another model of healthcare. We see this is a Medicaid program. This actually comes from Boston, because every now and again, a good thing comes from Boston. It's a model known as
That does play well in Providence.
Oh, yeah. And in Boston, surprisingly. This model is known as a medical legal partnership. And this ties together a lot of things I said before. So there's one of these in Roxbury, Boston, which is a poor, predominantly black neighborhood. And here's a real story. A person comes in with their kid, Medicaid clinic, and behind the desk is a social worker. And the person says, "Hey, my kid has asthma. My kid is sick. Hello." Social worker does a single intake, which is good, because you want to have a patient tell their story as few times as possible, so it's easier on them. There's a comprehensive intake that says, "Okay, yep, this is a medical condition. This is asthma. It's bringing down one door to a nurse or to a doctor. Doctor does the procedure, says, okay, yep, this kid has asthma. Fantastic. Here's albuterol. Go on your way." Social worker says, "Well, hang on a second. I understand in my line of work that childhood asthma is often caused by unsafe housing conditions. So let me ask you, what's your housing like?" And the patient says, or the patient's parent says, "Well, I live in Roxbury. I live in the slums. There is water in the walls. There is water in the ceiling, and I can't do anything about it because my landlord won't respond to my letters or my emails." Social worker says, "We can help with that," and brings them down another door, and there's a lawyer down there, or a law student. And they say, "Okay, yep, you've got legal protections under this thing. Here's a letter threatening to sue your landlord. We'll check back in 2 weeks or 4 weeks." And what do you know? The landlord got the water out of the walls, renovated. You have access to all these protections. You are entitled to these protections against things that make you sick, but you only have access to these protections if you can afford to hire a lawyer, or if you have the time or literacy or legal fluency to do so yourself. So it's a secondary kind of like a benefits you get only if you're rich. The social worker is providing a kind of healthcare in which he or she understands these kinds of benefits that are entitlements or protections and brings a person to them, which is the exact same skill set you need if you're a call center employee at an insurance company or a nurse at an insurance company. It's the exact same skill set of taking a person, finding out what they can get, and bringing them towards it instead of away from it. And you guys know Matthew Lesko? Matthew Lesko was a public access TV guy from the mid-90s. Another good thing from the 90s. He wore like a green Riddler suit. He was talking about free money from the government. There we go. Free money from the government. Buy my book. This dude's John was finding ways the government owed you money. Under single payer, we need to hire a lot of social workers whose John is finding all the kinds of healthcare you are entitled to by the government, right? Finding more people who work at these medical legal partnerships, more social workers, more case managers, more patient reps in hospitals, people who can be proactive and take you through healthcare, guide you, take care of you, give you like the comforting hand, help you stand up to or with or even sometimes against doctors to get the care that you need. This is the kind of work that saves money, sure, but is humane and fundamentally important to guaranteeing folks access to healthcare that they deserve and they need. And again, it's the kind of work you are suited for right now if you work at an insurance company. So we can let people who work at an insurance company, which I am one, use their skills to do the things that actually help people around them instead of be forced into harming, you could say, people that they work with. And that, to me, I think is a hell of a bargain for somebody who works at an insurance company. We're either going to fund care work the right way, or it's going to happen in shitty ways that exploit vulnerable people. So might as well do it right through the government.
All right. Tim Faust, thanks very much.
Thank you.
we are going to do some Q and A. And if you can, I'd like you to come up over here so I can give you my mic. And if you can't, I will bring you the mic or figure out some other way. But
Hello. I just want to first thank you for writing this book. I really enjoyed it. I love the language of it because it's unlike any other health book I read before. It's like I was like, wow, it's like the bitter pill, but not disappointing at the end. So
Yeah.
so I really enjoyed it. I guess my question is, because you mentioned home health and how it was included in the new bill by Bernie Sanders this year. But one thing I was interested about reading this book, what is one area you think that allies, people on the left, whatever you want to call it, are not advocating for enough when it comes to a single payer bill or Medicare for all bill, whatever terminology you want to use? What do you feel? Is it home health, or is there something one other area we're really like underutilizing, we're not really focusing on enough in terms of healthcare?
I think it is long-term care. I think long-term care provides a couple of different angles for organizing. One, organizing long-term care workers, compassionate laborers. Two, like people with disabilities are treated horribly in the U.S., right? Like the reason this care is like it's pretty wild. No dig on Bernie, but it's pretty wild to think this was a thing that could be like not be included as a part of the healthcare bill until recently, right? This is like I met a couple of folks in Tennessee whose kid had a disability, and he had to move to Colorado because in Colorado he qualified to receive home health. In Tennessee, he didn't. So he had to leave his family behind and travel across the country just to get home health. He had to move, otherwise he'd be trapped in a nursing home in Tennessee. There's a couple in where was it? In Memphis who famously, so they had to get divorced, so they made so they made less money so they could qualify for home health. They both had a disability, so they had to get divorced and sell their house and sell their stuff so they could qualify for long-term care. But 1 year, they made too much money on like their savings or whatever, and they made like $3,001. Were going to lose their home health, so they got together in a car and killed themselves in front of City Hall. Like this is the consequence of these like really punitive programs that penalize people for being poor in the wrong way or sick in the wrong way or being disabled. And so I think that there's a lot of agony and there's a lot of pain and there's a lot of organizing potential in the sphere around long-term care and home health. It's about respecting it's more disability. It's senior care too, right? You've got senior care, disability care, and then like this big burgeoning mass of compassionate laborers who are exploited and not represented. And I think across those three sectors, you've got a lot of things to fight for all at the same time. A lot of like rich nuance to organize and play with.
Hi. I'm Mark. First time, long time. Sorry for being a bit of a downer here, but I'm feeling a little black-pilled after the UK election results yesterday. So if the worst happens and we nominate somebody terrible like the Democrats are want to do, and Donald Trump is in there for 4 more years, how would you suggest we should continue the fight for single payer if we're under another 4 years of Trump? Do we just go into hibernation, or is there something that can be practically done at that time?
I think you win the things you can win where you can win them. Sounds a little bit recursive, but I mean it. The things that I'm most inspired by in the U.S. healthcare movements are not I think getting behind Bernie for single payer is like the clear and obvious correct thing to do, but I don't think that's where the fight ends. I think I've seen fights across the U.S. for things that are more material and more local, that are how you build the building blocks to build the movement that will win single payer. Bernie is not going to win single payer on his own. Bernie understands this. Bernie's trying to build a
best case scenario, he has a Democratic Congress that's to his right.
Right. Yeah. Bernie, there have been amicable senators and amicable presidents before, and they've lost to a massive, reactionary, very powerful capital class. And Bernie is not going to overcome this by himself, even if he is the president, knock on wood. What it demands is a massive movement, unlike the one we have now, much bigger in scope. And the way you build that is by winning things, I think, locally and stitching them together. So here's an example. Idaho is not by any means a progressive state. It is New Mexico for racists. Idaho did not expand Medicaid when the ACA passed. And I met a couple years ago, 3 folks in Sandpoint, Idaho, bought a Winnebago and painted it bright green and drove around the state to expand Medicaid because rural hospitals were closing, rural folks were getting sick and dying. There were like 200,000 people that were falling off the rolls that couldn't get health care. So they drove around the state and built a little movement. They do town halls in little cities and towns all across Idaho. They'd find anybody who wanted to organize and give them a packet of stuff. And they put together a petition to get on the ballot to extend Medicaid. And that petition got enough signatures and went on the ballot. And they spent the next 6 months cruising around the state, organizing everybody they could, canvassing, knocking on doors, calling, phone banking, doing whatever they could to get folks to turn out and vote for Medicaid expansion. They got on the ballot and then they voted on it. And they won 61% of the vote. Now, for context, the Dem candidate for governor lost by 22 points. So it's not a blue wave. It was a massive popular movement for local material gain. And then they won. And now they're not going away. Like, their fight isn't over. Now they're fighting for school funding in the state, and they're probably going to win that one too. But even if they lose, they still have built a massive power that they can begin operating from. In Texas, the movement for paid sick leave turned out 144,000 people in San Antonio, which is 3 times the number of folks that voted for mayor. 3,000 people more than voted for mayor in the prior election. These things that affect you materially are how we will build this mass movement. You must win them where you can, when you can, and from that build the movement that will win us a single payer. So if there is a very real chance that even if Bernie were to win presidency, he would not win single payer in his term, right? Because the odds are very stacked against him. He needs a massive popular movement that can fight with strikes, with a lot of different things to win and to demand single payer. And so our job, if Trump were to win, is to do the same thing we got to do now, which is to build that movement by winning the things you can win at home and building that coalition. Answer your question?
Thank you very much. I fully agree with many of the things. I mean, I just for background work in healthcare in the Boston area, so I recognize that I live in a total bubble that doesn't look like much of the country, and with extremely high insurance coverage and so on, and not-for-profit health plans that actually, in my opinion, seem to be doing a pretty decent job. Nationally, about 55% of people get in health insurance through their employer. What do you say to those folks who, and many of those plans, we are moving many of them to high deductible plans, which, basically is a way of reducing employer cost and putting it more on the individual, which is a terrible way to live and causes, all sorts of research that causes the people just skip going to the doctor until they're too sick. All the stuff that you were talking about, absolutely true. But many people really do like their employer-based health insurance. And what you're saying to them is, well, no, you're going to lose that, and trust the government. We're going to do that much better. Then they look at Medicare and they say, well, you're just telling me how shitty that program is. So why should I go for this single payer thing and trust a government that has not been able to deliver in that area when I kind of like my insurance? So I'm totally in favor of everybody that we should have as a basic right, universal coverage, universal, social insurance, social programs, all of that. I guess I'm just a little bit skeptical about let's just jump to single payer. So what do you say to the person who has decent employer-based insurance coverage with a health plan that they kind of like, which is roughly half the nation? What do you say to those folks?
Well, I got a couple of things to say to that person. One, I don't think half the folks in the U.S. like their employer-based insurance. I think folks like being insured because being insured kicks ass relative to being uninsured. But I like the right now the average deductible on a HDHP, high deductible health plan, is $5,000, and fewer than 40% of Americans have $400 in the bank. Like, this is already at an untenable position. There are some folks who are doing fine under this model and would do fine under the public option and would do fine under a Biden plan, but this plan is not for them. This is not this movement is not for those people. They're not the ones whose life is on the line right now. I think if I am talking to the comfortably insured, I guess I have these things to say. Right now, you lose your insurance already as it stands every year, right? You lose your insurance plan, you got to pick a new one. It always costs more. It always covers less. Even if you're in a union, that's the way that it works. This guarantees you need not lose your insurance ever again. You are not losing your insurance. You are getting better insurance. That one that doesn't have networks, does not have exclusions, that doesn't have copays or cost shares or deductibles. To compare it to like in the movement which demands a single payer and builds a single payer is not one that builds a modern Medicare. It builds something different, something more comprehensive. I don't think it's right now. Okay, you talk about accountability. Right now, your healthcare choices are determined by CEOs at Blue Cross and Cigna and Aetna and CVS and companies you can't control. You can't vote Cigna out of office any more than you can vote Jeff Bezos out of office, right? They have power over you. And there is no democratic accountability over that control they have over your health. Under single payer, you do have, like, you can find the person who is responsible for you, your rep, your House rep, your senator, your whatever, and go yell at them. You do have accountability over your own healthcare choices. You can find the person that there is a democratic ownership of healthcare plans, which you do not have right now under your employer-based insurance or your other insurance. I think this is to move towards accountability and to move towards democratic control of healthcare is I think unilaterally positive step and gives you more ability to control your healthcare choices. What we have now are at the whims of some arbitrary, uncaring third party.
Thanks. So I'm curious, talking about working a little more upstream, addressing kind of the social structural determinants of health, adverse childhood events that really impacts, a lot of what we do in healthcare, from primary care to a lot of, the specialty needs. I'm wondering how that fits in a single payer system. I think about lowering copays, lower deductibles. I don't know how those things tie directly into each other. How do we get money for housing first, under the healthcare system? Does that make sense?
Sure, yeah. So a single payer does not solve the problems of underhousing in and of itself. But I think it's the only thing which can be used to tilt at those problems in America. Once the single payer bears the costs of what happens when housing is not provided, it can be used to reckon with why those costs happen in the first place. This is happening slowly across the U.S., but it's happening on the private side through hospitals. University of Illinois in Chicago hospital is beginning to build housing for its underhoused patients because they go to the hospital because it's cold outside. Same with a big hospital chain in Orlando, but they're building 17, 23, 30 apartments. And they're putting, a dozen or two folks in there. Like, they understand that if they want to bring their costs down, they must put folks in houses, but that's determined by a private party, and it's not big enough. That's not the feature we want. I think a single payer that has to bear those actual costs of people not being housed is compelled to invest, or can be democratically commanded to invest in these housing programs. And you're seeing that in Medicaid. New York's Medicaid program spends a lot of money on housing and safe housing. California has a similar but not comprehensive enough program where the government does have, you could say, risk felt in people not being housed. It does invest in housing, and I think that once it has a much larger spending base than like the kind of paltry purse of Medicaid, that spending can be continued to build that housing. But no, single payer doesn't solve the problem. I think it's the only thing that can be used to begin to approach the problem, however.
I was wondering if you could talk a little bit about how single payer would interact with the drug war, institutionalized white supremacy, the prison industrial complex, expansion of treatment, and the role of how single payer could be used to address those systemic injustices.
Sure. So this is another one where I say single payer isn't going to solve this problem. Single payer can be used to address the problem, but single payer does not solve the problem. We understand the things we have done, the things we have done to address drug overuse, drug misuse, that kind of thing, right? You have the supply side attempts, the carceral state, these things that have not worked well at all ever, that has harmed folks and throw them in jail and tear apart family communities. And we have patient-directed care. We have drug or treatment. I forget the terms.
Medication-assisted treatment.
Thank you very much.
Which is actually not accurate. It should be medication for opioid use disorder, but that's okay. Or for addiction. This is a semantic thing that is. Sorry. I'm
very tired. I'm so sorry. Labor lost last night, and I stayed up very late morning. But you've got patient-directed care. You've got MAT. But you know the things that worked and haven't worked, right? I heard an interview with this dipshit in Indiana healthcare researcher who was getting behind a program in Scott County, where they sent cops door to door to knock on the doors and say, hey, do you guys have problems with opioids? How can we help? And unsurprisingly, it was sponsored by a private company. And unsurprisingly, this public-private partnership did not effectively curtail opioid misuse. So we know the things that do work, we know things that don't. It's medication, it's treatment, it's care. All we can do in a single payer is fund these things and not fund the things that don't work. But it guarantees treatment people that need it. I think the broader fight for decriminalizing and treating more humanely people who are battling misuse is a broader fight. I don't think single payer solves this, but I think it's, again, a tool which can be used in addressing it properly.
Something we didn't touch on earlier that I meant to ask you about is just how single payer frees people to fight for more freedoms.
Mm-hmm. Oh, so right now, if we wanted to go on protest for some reason, we wanted to go...
Can't think of anything.
Hit the streets. I don't know, things seem pretty good right now, so I can't think of it on a protest. We can't. Because if we have a kid, we lose our job, our kid has cancer, our kid gets sick, we got nothing we can do. If you work a couple of jobs and you have insurance, thank God, and your boss is an asshole, your boss controls whether or not your kid gets to get the care that your kid needs, or whether you get the care that you need. Your boss, your workplace has total domination over the literal existence of your body. You are not free in your own body as long as you are under the purview of your employer. Single payer breaks that. It unshackles us and gives us the ability to organize at home, at the workplace, wherever, to fight against broader and broader and broader goals and issues. I think that's deeply important for the future of the American left, is the idea that finally we can organize and not be bound by the needs of our flesh and the subservience to our employer to begin staging those fights.
So here in Rhode Island, the hospitals are going out of business, but we have a very thriving local community health center ecosystem. There's Thunder Mist, there's Tri-Town, and they opened up a new one in Central Falls last year. I was wondering if you could talk about how single payer would interact with community health centers, and if as you said tonight, if a sort of a pivot to more primary care, would my day-to-day healthcare look like I go to a community health center, or would we pivot back to hospitals?
In general, you want to take care out of hospitals because hospitals charge hospital rates, and hospital rates are very expensive. Here's an example of a thing that I think is cool. A single payer can't necessarily build more clinics and hospitals. It could, but it's not necessarily going to do that, right? It's socialized payment, not socialized providership. But here's an example of a thing that's pretty cool that kind of touches on your question. Consider Maryland. Great, you've considered Maryland. Western Maryland, Appalachian Maryland, is a de facto single-payer area. That single payer is Medicaid. Most folks there are low income or poor, don't have jobs or don't have high-paying jobs, and use Medicaid to take care of their insurance coverage. So that Medicaid program has a lot of leverage over how providers work in Western Maryland. And so for the past 15 years, past 20 years, what's happening across the U.S. happened in Maryland. Community health centers were closing down. Small rural clinics were getting closed down. Hospitals would buy up these facilities and close them down, because then you got to go to the hospital, and the hospital can charge hospital rates, or the hospital would buy up a clinic and charge hospital rates at that small clinic. And Medicaid said, we can't afford this. We can't afford this at all. So Medicaid commissioner in Maryland, Shannon McMahon, no relation to the WWE McMahons, decided to play hardball. She said, okay, here's what we're going to do. We're going to take these hospitals in Western Maryland, and we're going to pay you a fixed amount of money per year. We're going to pay you $10 million a year or whatever. You've got to treat everybody who comes through your door. You can't turn anybody away at the same level of care. Go forth and make your own profit. And so what do the hospitals do? They began reopening community health centers. They began reopening rural health clinics. They began undoing the things they had done for the past 15 years, and they made a 3.7% profit the next year, which is insane for a hospital chain. Is it good that we need to do this thing to the incentives of a private company? No, but is it better than the alternative? 100%. A single payer has that monopsony. You can use it in different ways to compel or coerce providers to do things that they otherwise would not do, and through that can kind of stem. CHCs are incredible, but this is an abnormal area. Having a robust CHC environment, community health center environment is not the norm across most of the U.S. We want more places like this and fewer where you have just like hospital emissaries across a region. And I think a single payer has the tools to build more things like a robust CHC environment and can do so across the U.S.
All right. Thank you, Tim. Thank you, everyone, for those awesome questions. And please buy the book. Please sign up for the Bernie campaign and the Physicians for National Health program and Providence DSA and everything else that's downstairs. And hope to see you back here on January 11th for our Bernie kickoff rally.
Thank you very much.
Thanks, Tim. Tim Faust is the author of Health Justice Now, Single Payer, and What Comes Next. Thank you for listening to The Dig from Jacobin Magazine. As Marx once said after noting that in communist society regulates the general production and thus makes it possible for me to do one thing today and another tomorrow. While other podcasts have only interpreted the world in various ways, our point is to change it. We are posting new episodes every week. The Dig was produced by Alex Lewis, music by Jeffrey Brodsky. Our communications coordinators are Julia Rock and Zachary Nin. Our senior advisor is Thea Rio Francos. Check out our vast archives at thedigradio.com. Follow us on Twitter at TheDigRadio, and please find us wherever you get podcasts and subscribe. If it's on iTunes or wherever, please take a moment to leave us a nice review. Those reviews help put us in touch with new listeners. What also does that is you telling friends about the show. Please, any propaganda made on our behalf is greatly appreciated. So is you going to patreon.com and making a monthly contribution to keep this operation going. Even a few bucks is a huge help.